Actually, I was hoping you will give a prognostic algorithm. So I understand there are a lot of variables. So which are the variables you give the most weightage in having a prognostic algorithm? For example, gut microbiome, there's a lot of variability on given days also.
So my talk was mostly to tell how little progress we have made, rather than give you something. It's more of a call to action that finally people are getting their heads together, because what youth in your hospital, in your setting, might be poor prognostic markers are not the same elsewhere. And an important thing brought out by Dr. Serene as well is the etiology of liver failure is very different. If someone has a hepatitis B flare versus alcohol-related hepatitis versus decompensated cirrhosis with a superadded infection, those three will necessarily have different trajectories just on the basis of the etiology itself. So it is very hard, and that was the point of us, to actually bring it to one common denominator. Clearly, organ failures, however we define them, the more organ failures, the worse you are. The question comes, how do we remove ourselves from this realm of obviousness that is currently permeating this situation to actually add things? And to that, I think maybe metabolomics may be one of the ways, if we can get our heads together and pool all our data and figure out if that could be an additional card there for us to play. More importantly, to say who will do badly in the absence of transplant, who will do well in the presence of transplant, and so on and so forth. Because we also have to figure out, if we put them up for transplant, will they live after transplant to an acceptable degree, whichever situation we. So sorry, I don't have a good answer for you, but that's the whole point here, is to actually generate some controversy so that we can come together.
Microphone 3.
My question is to Dr. Serene, sir. An excellent talk, sir. I have two questions, sir. The first one is that you have talked that for moderate ascites, means if you have to do for a paracentesis of 3 liters in an ACLF patient, we have to give albumin. So how much albumin do we give? Because traditionally we have been taught that after each 5 liters, we have to give 6 to 8 grams per kg. And the other question is that you talked about a Eat Early study, where the diagnosis of when patient had AKI and ACLF, at 12 hours, the patient was started on terlipressin. So during the first 12 hours, how much dose of albumin was given, and will the Indian patient tolerate that much dose? Thank you.
Very good question. So we tap 3 liters. Normal abdominal pressure should be 5. In all ACLF, you will have pressures above 20 generally. So if you bring down from 20 to 12 in just about 4 hours, the patient gets into PICD. So slow decompression is a better way. Albumin is again same, 8 grams per liter. So if you have tapped 3 liters, about 20 grams is good enough. In Eat Early studies, for first 12 hours, the patients were given 20 grams of albumin, no more. If you give more, they do not tolerate, they go into pulmonary edema. I am not a proponent of albumin in ACLF, but if you are tapping, then, or if you have HRS, then only I will give albumin.
Thank you, sir.
May I ask both of you questions, Steve and Jess? Now, conceptually, ACLF is a group of patients who have underlying chronic liver disease, known or unknown, who rapidly develop liver failure. You define liver failure in different fashion in ESL and APSL. APSL you define there is evidence of acute liver injury followed by features of liver failure. ESL define acute decompensation of part of liver failure. But the final endpoint is short-term mortality, or 28 days mortality, which is very high. That's why you separated this group as acute-on-chronic liver failure. That was the basic concept. Now, by doing these various definitions, have you shown that this mortality rate, in hospital mortality rate, is different in different definitions? That is my first question. Question is, I remember SEEP initially argued that only liver failure has a 30% mortality. Therefore, he told bilirubin more than 5, INR more than 1.5. Within 4 weeks, ascites are onset of encephalopathy. So we defined that ACLF. And he defined a window. My question to see you is, first question. The second, how many patients we have a window and how many you turn around? Because you have an arc base. By now, we should have known what is that proportion of patient who has the window and what is the proportion in early definition, we are turning them around. What Bajaj asked, told, early, late, too late. Is there a reversible component? So that is why all of us are confused.
Okay,
And
I'll speak a little bit.
that's
and
the
then I can
biggest
go-
problem.
Okay. So
And
the-
that's why the treatments are all treatment of liver failure.
It is quite clear that it depends, like in real estate, location, location, location. You know, where your patient is where you actually determine. Most of our patients in the West are people with already diagnosed cirrhosis who come in with an insult that is most likely extrahepatic, not intrahepatic. Okay. So if we say, okay, we are only going to use the APASL definition, and those people don't have ACLF, we won't give them extra points. We have to treat the patients that we see. Same with APASL. You have people with predominantly liver failure or liver cancer. So I think the way we figure it out is actually, like you said, who dies and who lives, and reverse engineer. The NACL definition was based because of that, because we had no things going in, and we wanted an easy definition. What it ultimately ended up happening was these people were futile. So it actually affected only a narrow slice of people because it was too late. But it was also valuable because it gave us an insight of who will not do well after transplant and who is not reversible, to your point, in that situation. What we want to do is to actually do a protocolized way of doing things. Clearly, people who have ACLF grade 1 and 2 with the EASL definition and the low grades of APASL will do very well. The ones with higher grade, I'm not aware of any big smoking gun difference between the higher grades. The higher grades are bad regardless of whatever definitions you take. So that's two. I forgot what your second question was.
So I appreciate the wisdom of Dr. Acharya. He actually has put the thing in perspective. First, decompensated cirrhosis is going to die his natural death, and clubbing it together just because he's dying in 28 days into a transplant list, we put them into ACLF may not be the wise, and that can create confusion. Now, a decompensated cirrhosis may live for 2 years, but those who will living only 28 days high mortality were placed into this, so that, and as Jess also says, these definitions were evolved so that they can get priority on transplant listing and can be considered. But to simplify as a science, I think the clarity is that people who have just pure liver failure, which has 3 parts, coagulopathy, liver failure and HE, and portal hypertension, which is missed into all others. Portal hypertension is the cause of bacterial translocation, pneumonia, SBP, all of that. So an acute portal hypertension is missed into all other definitions. So this is the advantage of having this definition, and patients have, even if they have got ACLF 1 according to them, or for us just R grade 2, these patients can also have high mortality. Now coming to whether can we, and our database, could we convert some into and reverse? That is a question we are struggling with. You know, I showed you the concept of reversibility. I looked into the database of 3,200 odd, which is ASLD oral. Out of that, we realized 420 odd only were reversible. Means at 90 days of the 3,000, only 400 reversed. Rest continued with the liver failure. So it is not easy. They stabilized, some died, but reversibility of 90 days is not a good idea. Maybe they reverse at the end of 6 months or reverse at the end of 1 year. Portal pressure comes down, ascites improves, jaundice, coagulopathy persists in many of them.
A very important wrinkle in what Dr. Sareen was saying and what you were asking is the availability of transplant. At some point, if you have a patient, the higher the MELD score, the more likely they're going to be on a transplant list, especially if it's a national deceased donor list. Then the reversibility is in the eyes of the beholder. If the patient got a transplant, for me, that is a win, because that patient was not going to get better anyway. Whereas if you do not have availability of a transplant, you do not have a donor, you do not have the financial capabilities, then yes, exactly what you're saying. You want the patient to get along with their native liver for as long as they can. So this is why it makes it very challenging. That's why there's not a simple answer to this very important question, because there are some people whom you want to keep high because of the liver transplant eligibility, which they ultimately end up getting.
Thank you very much. I think the topic is very interesting, and we could stay here for hours to make questions to these two leaders in the field. So thanks again. Thanks for the excellent presentation. Thanks for your question. And now we give the words to the next session. Thank you very much.